The median overall survival for the tivozanib arm was 28.8 months, and the median overall survival for the sorafenib arm was 29.3 months. There wasn't any statistically significant difference between the two arms, but the slightly longer median overall survival for the sorafenib arm is intriguing. The reason that this was observed was that in the design of the trial, when patients were randomized to sorafenib and they progressed, then they were offered tivozanib on an extension protocol. The reason that we did this was for the benefit of the patients. We felt that the patients enrolled on the trial wanting this promising new targeted therapy, and if they progressed on sorafenib, then we felt they should have it. The effect really was when we looked at the number of treatments that patients had on both arms. Many of the patients that were randomized to tivozanib, when they progressed, didn't get any other targeted therapy. They were treated in countries where it wasn't available. On the sorafenib arm, though, when they progressed on the sorafenib arm, they had access to tivozanib. So what we found is the patients who were actually randomized to the sorafenib arm had a higher number of treatments. Most of them had at least 2 or more, whereas the patients on the TIVO arm only had 1 drug. And so I think the takeaway is that sequence therapy is better. More access to more drugs is better for patients. The more drugs that the patients have access to, the better off their survival will be. I think that's one takeaway from the trial. And the other is the fact that the survival with these targeted drugs is really becoming longer for patients with advanced kidney cancer. Before these targeted drugs were available, the average survival was only about a year. But as shown here by the tivozanib in this trial, with targeted drugs, the median survival is being pushed out to about 29 months.